In 2022, EUFOREA launched its first Global Rhinosinusitis with Nasal Polyps Awareness Day. It was part of a broader strategy to raise awareness of this debilitating and often underdiagnosed disease of the paranasal sinuses to both patients and healthcare providers. One of the biggest frustrations that became evident was that although it's a common condition, it is often overlooked in policy discussions, and it's lumped in with other comorbid conditions such as asthma. One major issue that continues to be raised and widely appreciated is that the name chronic rhinosinusitis with nasal polyps, or CRSwNP, isn't exactly easy to impart. It isn't widely understood and really isn't helpful for patients. So, should we change the name of the condition to help patients, physicians, and also to improve care? What's in a name? Let's talk CRS. Hello, I'm Dr. David Bull, and welcome to this EUFOREA Innovation Forum debate. Chronic rhinosinusitis with nasal polyps, or CRSwNP, is a chronic inflammatory condition of the nose and paranasal sinuses. It affects about 1 to 4% of the general population and about 30% of patients with chronic rhinosinusitis. It's caused by type 2 inflammation, and that means that patients often present with comorbidities, including asthma and allergies. The symptoms can be very distressing and include nasal obstruction, smell dysfunction with anosmia, continuous nasal discharge, and facial pain, all of which profoundly impact patients' quality of life. As I mentioned at the top of the show, last year saw the launch of the first Global Chronic Rhinosinusitis with Nasal Polyps Awareness Day, aiming to raise awareness of this debilitating and widely underestimated disease. Education of patients and healthcare providers is utmost in EUFOREA's mission. One of the biggest frustrations is that CRSwNP remains overlooked in policy discussions and is all too often grouped alongside its more commonly recognised comorbid conditions such as asthma, atopic dermatitis and respiratory allergies, despite patients' continued efforts to voice their unmet needs. The theme of the 2022 Global CRSwNP Awareness Day and campaign was called Let's Talk CRS. It was and it remains EUFOREA's goal to help empower patients with chronic rhinosinusitis to talk knowledgeably about their condition and arm them with information to help them in conversations with their doctors to ensure they are productive consultations and that it leads to improved outcomes. So, what are patients most frustrated about? Well, discussions with members of EUFOREA's Patient Advisory Board revealed that patients feel, firstly, there's a lack of available information about their CRSwNP. Secondly, they feel there is a lack of empathy from their peers and also from their healthcare providers. And lastly, one of the biggest barriers to finding correct information online was the inconsistent naming of their condition. Other findings from the Patient Advisory Board showed these shortcomings in particular. Firstly, a lack of personalised care. Secondly, a lack of patient participation. Thirdly, a general underestimation of the burden of the disease by society. And finally, limited treatment options with limited access to novel treatments. In response to this, EUFOREA is working hard to adopt the suggestions put forward. This year, EUFOREA's Global CRSwNP Awareness Day aims to build on the work already done to improve communication between patients and their healthcare providers in an effort to achieve optimal outcomes for all patients. Physicians across specialities are now becoming more aware of existing resources such as EUFOREA's Chronic Rhinosinusitis Pocket Guide and its treatment algorithm. The question now is how can we get more patients to see their doctors for an appropriate diagnosis and optimal treatment plan? One overriding thing that has come up in all our discussions with the Patient Advisory Board is the potential name change of the condition. Would a name change make it easier for the patients to research their condition? Would it improve communication in that all-important 10 minutes with the healthcare professional? And would it benefit the healthcare professional, leading to more empathy, a faster diagnosis, and accompanying treatment? Well, to discuss this further, I'm delighted to introduce our panel of experts and patient advocates. Representing the medical community from the United Kingdom, Professor Valerie Lund. She is Honorary Consultant ENT Surgeon and Professor Emeritus Rhinology at University College London. Also from the United Kingdom, Professor Peter Howarth. He is Global Scientific Lead Biologics in Medical Affairs within the Specialty Medicine Therapeutic Area at GSK. Representing the patient community, from Canada is Jeff Preyra, who is President of 360 Story Lab, and from the Netherlands is Thijs Theeling. He is the EUFOREA Patient Advisory Board Chair. Well, let's start by looking at the condition from the purely medical side. If I may come to you, first of all, Professor Lund. Earlier on, as you know, I pretty much outlined, I thought, a summary of the condition, the symptomatology, the comorbidities, and the impact of the disease. Hopefully I did a pretty good job. Is there anything else that you want to add at this stage?
No, I think you did a really excellent summary of the condition and the comorbidities. Let's hope that people appreciate that there are these many other associated problems. And I think the importance of the quality of life impact is really a serious one, and something which is underappreciated generally across the general public and across the medical profession.
I mean, clearly what comes across very much, and I've spoken to a lot of patients as well, is clearly this can be extremely debilitating. And I think patients also feel that sometimes it doesn't really get through, that they don't really get the information from the medical professionals. Would you agree with that?
Yes, there's no question that it's very much underplayed within the healthcare system, because certainly from a primary care physician's point of view, it's not a condition that people will die from, and the actual morbidity of the condition is very much underrated, even though we've known for nearly 30 years that the quality of life impact of these diseases is as great as things such as angina and other serious chronic diseases such as insulin-dependent diabetes. It just somehow hasn't got across to the general practitioners, particularly, that this is a really high impact disease.
If I may stay with you and talk about this from an ENT perspective, how does the community of ENT specialists name the condition, this condition of chronic inflammation of the sinus cavities? What do you call it?
Well, when I started a long time ago in ENT, we did talk about nasal polyps for sure. But over a period of time, we sort of developed the concept, certainly in the 1980s, of rhinosinusitis, in order to emphasize that A, it was inflammatory, and B, that it was difficult to define where the condition stopped in respect of the nose and the sinus system. Although one area might predominate, it certainly was a thing that was affecting the whole of the upper respiratory tract. And so we coined the term chronic rhinosinusitis. And it took a long time for that to be picked up. In fact, there was considerable resistance to it to start with, largely due to coding and financial considerations. And having got that sort of concept across, obviously we then started talking about CRS with and without nasal polyps to try and define the division on a pragmatic basis, from looking in the nose with an endoscope and seeing whether or not polyps were present. It was a simple way of making that division. And by and large, that is a term which I had continued to use for many years. I think with our increased understanding of some of the underlying processes that are going on, there has been a sea change, certainly through EPOS in the most recent document in 2020, to try and drill down a little bit more into the underlying pathophysiology, and not to be so binary in determining whether or not polyps were present or not.
That's really interesting. If I may bring in Peter Howarth now. I mean, clearly you're an allergist, you're a pulmonologist by trade, so we're moving from the nose to the lungs here. Is the name that Valerie just talked about, is that well known? Is it used amongst the pulmonology community?
Yes, I would say that it probably is. I think that, historically, one would have to admit that I think pulmonologists have tended to overlook the upper airways and concentrate on the lower airways. I think that has changed, and I think probably the advent of biologics as systemic therapy has led people to be more aware of the upper airways and their importance.
And Peter, you and I know that as physicians we become very immersed in our own specialities. I mean, is there a danger here that we're almost talking slightly different languages when you've got ENT physicians talking one language, you've got pulmonologists talking a slightly different language? Is that sometimes a conflict of interest?
No, I think, as I said, I think there's been a lot more concordance that people work closely together for patient benefit now. And so, in the area of severe asthma, the importance of the upper airways and the presence of chronic rhinosinusitis is now well recognized. And there's a multidisciplinary approach for patients. So ENT surgeons are commonly involved in the co-management of patients with severe asthma. I think the other way round, patients with chronic rhinosinusitis with nasal polyps, many have asthma, but it may not necessarily be severe asthma, so perhaps there's less of a need in that direction.
Valerie, if I may come to you after Peter's comment. I mean, in terms of different modalities, you've got different specialties. Is there a danger, actually, that sometimes the different specialties are talking slightly different languages and therefore we have a barrier to mutual understanding?
I think you're right up to a point. I mean, it is difficult for the general practitioner, for example, who can't look in the nose with an endoscope to make a diagnosis of nasal polyps. All they have to go on really are the symptoms of the patient. Though I think in primary care, people have started using the term rhinosinusitis more generally. It's a difficulty we have in communicating and educating, our own colleagues in what we use in terms of terminology. Particularly, if we start to change things again. I mean, we would like perhaps to use a term like eosinophilic rhinosinusitis rather than talking about polyps or non-polyps as a way forwards. And that might bring us actually into better alignment with the pulmonologist, but it wouldn't necessarily help the GP.
Well, let me ask Peter then, would that appease you to have eosinophilic chronic rhinosinusitis? Would you like that one?
Well, certainly, that's a term that's well appreciated in Japan, where they talk about link the underlying pathology with the condition. I think from with a pharmaceutical hat on, I think one of the difficulties in changing terminology is if you have a treatment that is licensed for a condition, that license includes the terminology, and so changing terminology would then present difficulties.
I completely understand. I think that's an incredibly valid point. Thank you very much to both of you. So what I want to do now, if I may, is to look at the frustrations shared by patients and indeed by physicians as well. But let's start with the patient experience. Jeff, if I may bring you in at this point and let me ask you this first question. What do you call your condition when you speak to your friends, when you speak to your family?
Well, that's interesting, David. When I speak of it, I talk about it mostly as a cluster of symptoms because it doesn't have for me, I wasn't aware that there was a name per se. So I would talk about having chronic sinus congestion. I would talk about losing my sense of smell. I would talk about getting constant postnasal drip, having trouble breathing, those kinds of things. And then I had heard the term chronic rhinosinusitis, and that sounded not that my friends understood that term, but I did like that term because it kind of described, what was happening.
I mean, it's quite a mouthful. Did your friends and family sort of understand that? Was it helpful actually to have a label?
I think it would be really very, very helpful to have a label that would, it's descriptive and yet that would be easy for people to understand. Because I agree, what Valerie had said earlier, and I think Peter as well, that people don't really take it seriously because they say, oh, well, I've lost my sense of smell. And they go, oh, yeah, okay, fine. Or that you have a runny nose. Well, everybody has a runny nose. And, a lot of the symptoms that I was presenting with are indicative of other things that people have had, which are very minor or transitory. And, they weren't aware that it was part of something, quite a bit deeper and much more difficult.
Thijs, let me bring you in here. When you're talking to your friends, to your family in the Netherlands, what do you use? How do you explain your condition?
Well, let me say, if I would say to my friends that I had a chronic rhinosinusitis with nasal polyps, they would think that I try to impress them with medical abracadabra. It's for non-English speaking people, it's even a tongue breaker. So what I always say I have a blocked nose and a lack of breath. And the interesting thing is, if I say that I have severe asthma, that is more impressive to them than to say I have a blocked nose. Although my nose problem is worse than my asthma problem.
So that's really, really interesting. Okay, so again, everyone is using different terms. Also, Thijs, when you speak to your primary care physician, do you tend to use different language as opposed to when you're talking to your specialist, for example?
Well, now you're touching a sensitive point. When I talk to my family doctor, I had problems with my nose since I was 6 years old, and they were always telling me this is part of life and there's nothing special on it. In that respect, I was lucky that when I was 52, I had an attack of severe asthma, and the pulmonologist was the one who turned me to the ENT, and finally they came up with a solution. So it took 55 years to find out this is not just a snotty nose, which is part of life. This is a severe problem.
Wow, gosh, that long. So as now, if we look at now, after all of these years, having been given an appropriate diagnosis, do you use different language with your primary care doctor?
Yeah, I will. I try to arrange to say to them that I have a nasal disorder, in hope that they understand what the problem is.
Yeah.
But to be honest, I almost do not see my family doctor for this anymore. I go directly to the hospital.
Okay, let me ask the same question to Jeff, if I may. I seem to have, as Thijs says, touched on a nerve here. Do you tend to say something different to your primary care doctor as opposed to when you're talking to your specialist?
Yeah, I'm kind of with Thijs on this because there were many years, and I did not get proper treatment for my condition until I was in my 50s. So I suffered with it for many, many years as well. And I do have a terrific family doctor who, prescribed many things and tried many things down the road, but he did not know. He did not have any knowledge about the underlying condition. And just like Thijs, now I don't see my primary care physician for this at all. I only go see my ENT.
That's so interesting. So you've bypassed the primary care doctor. Both of you have done that in completely different countries. Staying with you, Jeff, if I may. When you're talking to your friends and family and you're trying to explain this quite complicated condition that can manifest in various different ways, what do you tend to say to them? If they say, for example, what's the most kind of bothersome part of your condition? What's the biggest symptomatology? What's the thing that really irritates you? What do you say?
David, it's interesting because my symptoms, they went as a sort of cascade. It started off with, a sniffly nose, and then it went to, I was getting chronic sinus infections. And then I started getting asthma symptoms, which I had never had asthma in my life, but I developed asthma, and it made breathing difficult. And then my asthma got so bad that I had trouble sleeping and I had trouble working, and it became quite a burden. So most recently, until I started getting a proper treatment for that, the talk was mostly about my asthma symptoms. But my friends were aware too that I would tell them that I had lost my sense of smell. So, going out and eating with them, or even eating at home and stuff, it wasn't as enjoyable anymore. And, frequently very kind of dangerous, because if you can't smell your food, you can't tell what you're eating. Or I have a gas stove in my kitchen, and there was one time where the pilot light went out and the gas was still running, and I couldn't smell it because I had lost my sense of smell. So that was something that turned out to be quite dangerous as well.
Well, absolutely, and of course had a profound impact on your life, or could well have done, actually. But also, I assume it also changed whether you wanted to go out and have dinner with your friends as well. If you can't smell the food and you're not enjoying it to the same degree, you probably didn't want to go.
Yeah, absolutely. It was quite my quality of life was much worse, because eating even the best food was not really interesting. And I would eat a few bites until I was not hungry anymore, and then I would stop. And as a result, I started losing weight, which I didn't want to do. And I didn't enjoy cooking anymore, because I used to cook a lot. I do now again, but just in between when I had lost my sense of smell, I had no interest in cooking. And there's a whole other host of symptoms that go along with that. Many of them not quite obvious.
And Thijs, if I may come back to you and ask you the same question, how do you describe your condition? What for you is the most bothersome thing? What do you say to your family, to your friends?
Well, it's two things, I would say. It's the lack of breath is really a thing which is hurting me, especially during the night, because that prevents me from sleep. That's so that worries me, and that's what I say to my friends. The funny thing is that the most important thing is that a lack of smell and lack of taste, I do not say to my friends. I had the reputation of being a connoisseur in wine, that even my French colleagues did not dare to ask for a wine before I gave my advice. Thank God I have a good memory. So for a couple of years where I had no taste at all, I was always testing the wine first and give my comments, because I'm very good in reading the label. So I know how a Syrah grape makes, and that the difference between a Merlot and a Cabernet Sauvignon, but it's horrible. So, and also the dangerous thing is that if I like cooking, and sometimes you forget that you have something on the stove, and if your food is burning, it smells all around the house, but I don't smell it. So my wife is coming and say, "What the hell is going on over here?"
So very similar indeed. Just very quickly, the terminology CRSwNP, do you ever use that? Is that helpful?
I never use that. I even, every time if we talk to each other, I have to look in my notes to see what the abbreviation was, because, chronic rhinosinusitis is already a big problem for me.
Okay. And Jeff, can I ask you the same thing? Have you ever used that term, CRSwNP?
No, I've never used that term. It's too unwieldy, and it's, I often, like Thijs, have to think about getting the letters in there in the proper order. And I said, is that right? Chronic rhino, what? So no, I never use that.
Well, that brings me nicely. Let's go back to the physicians. Valerie, if I may bring you in here and say, look, I mean, clearly these are really confusing terms, and clearly we've heard from two different patients where we're hearing pretty similar stories where this terminology is really not helpful to them, to their families, or anyone they associate with.
Well, nobody empathizes more than me with patients with these problems, because I've looked after them for decades, and I know how dreadful the condition can be. I just have an anxiety about, what we're trying to achieve by making the name simple. Because thinking about it from the perspective of the condition and the physician, if you take away, inflammation, if you take away duration of disease, if you take away the concept of cure as versus control, that this is not a condition that's going to be easy to cure. In fact, we're looking at control for it. You sort of strike at some of the fundamentals of understanding the condition itself. And I've absolutely no objection to the term nasal polyps per se, but it just seems a bit reductive to me. We seem to be sort of putting the clock back a little bit, rather than saying, can we make the condition more understandable for people? If we say you have nasal polyp syndrome, as possibly been suggested, that's fine. But then what is nasal polyp syndrome? It has to be diagnosed in secondary care, because if primary care won't be able to diagnose it, neither will a patient until they've actually got as far as secondary care to have that diagnosis made. So I think there are some, disconnects here. And it's really a question of what the purpose of the change is. And if we change it, are we going to change it right the way up and right the way down? And is it something that's going to be easy to communicate, as Peter has said, in terms of how we manage the condition?
Yeah, I think you make some really great points. They're very valid points. I'll come back to some of those in just a minute. I just want to bring Peter in, if I may, at this point. Really the same point I put to Valerie, which is we've got two different patients pretty much saying the same thing, saying they don't really understand the naming, the nomenclature. It clearly doesn't work. So do you think we need to move to some sort of uniformity, as I was saying to Valerie, or do you share her concerns that actually brevity might actually destroy the very essence of what we're trying to do, and possibly what we need to do is to inform patients to a better degree?
Yeah, I think historically, as better understanding of different conditions come forward, names do change. And, you mentioned, eosinophilic chronic rhinosinusitis. But I suppose from a patient's perspective, that may not be very much difference in a mouthful from saying chronic rhinosinusitis with nasal polyps. So, I would like to hear from Jeff and Thijs, what their thoughts are. I think many patients like to have a diagnosis and a label put on it, whatever their condition is, but they don't necessarily have to use that terminology, and often patients talk about what is their most troublesome symptom. And so I suppose it depends where you think a label is most important to be used.
Yeah, Peter, thank you very much indeed for the moment. So again, what this seems to be coming to, and listening to what the patients are saying, and indeed the physicians are saying, is about something that I think we're all sort of starting to agree on, and something that really has been nagging me for some time over where we're going, and whether we should really consider a name change. And that's a broad question, actually. So let's just go back to the patients themselves. If I may go back to you, Jeff, would you be happier if we had a simple name, a name that you could use the whole time, that would impart kind of the information about the condition that you suffer from to your friends, to your family, to your work colleagues?
Having a simpler name is great, because then you can say to someone, here's what I have, and then they could go Google it and find out what it is. I can go to my primary care physician and say, I've been diagnosed, my ENT has diagnosed me with this, and they would understand what I'm talking about. So yeah, I think it would, but to, I thought that Peter made a really excellent point, is that I deal mostly with medical professionals, and they, regardless of what the name is, they know what the underlying pathology is. They know, what my symptoms are, and they know what the treatment options are at that level. But I think the real challenge is, getting primary care physicians to understand it well enough to get proper follow-up care for their patients with a specialist.
Yeah, that's a really good point. Thijs, can I ask you the same question? Do you think, would you welcome to have a simpler name, a name that actually would resonate with primary care physicians, with specialists, with friends, with family, and so on?
Yeah, I absolutely. I think that's a good idea. I also have the feeling that we mix up things over here. The fact that the medical community uses another name, that's okay. In the public, everybody knows what a heart attack is. Although the cardiologist, well, they will not talk about a heart attack. They will talk about the specific symptom. So we're talking here about two things. So that the medical community using chronic rhinosinusitis with nasal polyps is no problem. But for the public, the general public, and also for creating an awareness that this is really a serious thing and not just a snotty nose, I think it would be good if there is a good name. And I personally like nasal polyp syndrome because it gives you the idea that it's really nothing. It is something serious. Although what I will do is just check around in my environment what they think about, and they say, well, it's too complex. You should say nasal disorder. But I personally like a nasal polyp syndrome.
I think you make a fantastic point there, which is, of course, as you say, colloquially, people talk about a heart attack. Of course, medics will talk about a myocardial infarction. So just in terms of this name that's been suggested by the advisory board of EUFOREA, this is nasal polyp syndrome, you would welcome that, would you, Thijs?
Absolutely, absolutely. I like it because it's clear. Everybody understands what a nasal polyp is, and syndrome makes it a little bit more serious. Just like there's a difference between asthma and severe asthma.
Okay, Jeff, would you welcome that change to nasal polyp syndrome?
Yeah, I would. I think having a simple name would be great in communicating, outside the field of specialists. So a simple name would be great. And I've heard the name nasal polyp syndrome too. I think it's a decent name. And I think that if we adopt it, we're all going to get used to it and people will understand just exactly what it means. Short answer, I think having a simple name is very useful.
Are you happy with, sorry, may I just butt in? Are you happy with the word syndrome? Does that have any sort of negative connotations for you?
Not really. I don't know if I find the word syndrome particularly useful. I don't know if it speaks to the actual, pathology in a way. I like that word, like rhinopathy, like polypoid rhinopathy, or something, something like that. But that being said, names come out and then people get used to them, and then the name takes on a life of its own. And so I think after a little bit of time, I think the name will probably serve okay.
Valerie, I'm going to bring you in here. I imagine that you may not agree, but what about that? Obviously the patients are saying, look, we need a different term. We need something that's more user-friendly, so nasal polyp syndrome. What about using these two different terms? So the physicians continue to call it chronic rhinosinusitis with nasal polyps. The public, Joe Public, says, I've got nasal polyp syndrome. They are synonymous. They're the same thing, but they're just different terms.
No, I've got absolutely no objection to that at all. If that's acceptable to, I'll call them both parties, but of course it's a spectrum and it's an overlap. There's absolutely no problem with using alternatives. I think we have to be clear what nasal polyp syndrome actually means. I mean, syndrome is simply a group of symptoms. So, what symptoms are we talking about? Are we implicitly going to promote the idea, we hope, that it also involves the lower respiratory tract and asthma and possibly aspirin sensitivity, etc. So I think that it has some advantages, but it'll still come back down to sort of education as to what we're meaning by that catch-all term.
Yeah, Peter, can I bring you in as well and say, what do you think about that? Having two different names, one for the lay person and one for medical professionals. Would you welcome that?
I don't know about necessarily welcoming, but it has precedent. You talk about atopic dermatitis and eczema, and they're recognized to be the same conditions. So I think providing there isn't confusion that that they are not different conditions, as I highlighted before, when you have a treatment that is licensed for an indication, changing the name presents difficulties, but if the two are both seen as being synonymous and can be interchangeable, then if people feel that that's more acceptable or more readily understood, then I don't see a significant issue in it.
I mean, one thing that strikes me, and Valerie, I think, made reference to it, I think you did as well, is about the primary care physician, because obviously that's often the first port of call for many patients. And it seems to me that actually what we need to do here far more is to have more information, more education of the primary care physician, because it seems to me they don't always know what they're talking about, they're not up to speed, and clearly they don't have the level of knowledge that a specialist would have.
I would say that I think that perhaps there are some advantages in primary care for nasal polyp syndrome, because, as Valerie said, syndrome is a collection of symptoms. And often in medicine, it's very much pattern recognition, that when you see these symptoms go together, and when you find a patient with those symptoms, it triggers the thought, could this be nasal polyps? Could this be chronic rhinosinusitis with nasal polyps?
And Valerie, I think one of the other things that both our patients have touched on is actually it's really difficult to research anything, because you've got so many names doing the rounds that actually if you did use this colloquial term of nasal polyp syndrome, you could Google it, you could go onto any web browser, put that in, and then everything would come up under it. It's quite an interesting, good banner, isn't it? It's a catch-all.
It is. I think the trouble is that there's overlap, obviously, between the symptomatology of nasal polyp syndrome and CRS without. I mean, what are we going to call CRS without nasal polyps then? Sort of non-nasal polyp syndrome. I think there are some inevitable difficulties here. The terminology that you see, obviously, in the literature is pragmatically based on people looking in the nose with headlights and endoscopes and saying, yes, there are polyps there and not there. I think there might be some difficulties in making that transfer from nasal polyp syndrome into the medical literature for randomized controlled trials and such like, for those reasons. But I mean, there is no harm in having a colloquial term which the general public understand very clearly. And if GPs understand that a patient who's got nasal symptoms that include predominantly loss of smell and nasal obstruction, they are, together with, say, asthma, then they are very high candidates for having nasal polyps and might make the referral a bit earlier.
I mean, clearly there's buy-in from you and indeed from Peter, but across the specialities, do you think there would be resistance to this?
Well, I wouldn't presume to speak for the other specialities.
Well, no, fair enough. Peter, would you think there would be resistance from some sectors of the medical profession to this?
Well, it's difficult. It depends where you're coming from. There has been very much a move in some circles towards what's called treatable traits, where you identify the underlying pathophysiology and you provide the treatment that's targeted towards that, and to move away from labels. But certainly heard from Jeff and Thijs that having a label that is readily usable and recognizes the nature of the condition and its severity has its attractions. So I think there's arguments in both directions.
And so really, finally, it brings me on to say, well, where do we go from here then? If we all think it might be a useful thing, it might be an interesting idea, how do we move this on, Peter?
Well, as was mentioned, I think if terminology is used, it becomes gradually more accepted. But I think, as Valerie said, I think you can't do away with older terminology because it has a position, and I think that one would be looking to see the terminology occurring, together and matching together.
So just to summarise all of this, and very quickly, if I may, let's get your final thoughts then. It's been really, really fascinating, actually. Now we've sort of come round to the idea of having two sort of terms that are used in parallel. Jeff, what are your final thoughts on this? Would you've said you would welcome this. Anything else you'd like to add?
I think what would really help is if some famous person got this disease, and then we could just name it after them. Like Lou Gehrig's disease or something like that. And then we would have a more, the more formal name to use in a clinical setting. But I do think a combination of two names, a simpler kind of shorthand for the disease would be useful. And then preserve the more clinical name. I thought Peter made a really good point about, in drug approvals and so on, it's designed for treat a very specifically named condition. So I don't think we could change the name easily, or should. But I think having a simpler name to use at home and with primary care physicians, I think could be very useful.
And Thijs, anything you'd like to add?
Yeah, I think Valerie made a very good point in saying everything has to do, as important is educational item. Make it clear what it means. Make some publicity about it. It's like COPD. Nobody knew, I think 10 years ago what it was, and now everybody hears about it and they know what it is. And I think if you want to make this name more famous, then you have to do something on the educational point. So create the awareness. What is nasal polyp syndrome?
A very good point indeed. Peter, anything you'd like to add as a final comment?
No, I think that the fact that we've had a good discussion and the points you've raised, illustrates, that it's not unreasonable to be thinking about how best we can communicate the condition and its impact on patients and severity, and that if a more simple term in everyday use enabled that, then that would be a positive thing.
And finally, Valerie, let me come to you. Your final thoughts, summarising everything that we've spoken about.
I think it's extremely useful. I think it's very, very important having, engaged with patients to tell us what they think about these terms, because otherwise we will never end up with the best treatment and the best communication that we can have. And I've certainly no objection at all to a simple term, as I said, with the educational caveats that go with that. I'm not wedded to CRS with nasal polyps. In fact, as you know, with EPOS, we've tried to get away from that as well and talk more about the inflammation, whether it's ECRS, eosinophilic CRS, or non-eosinophilic CRS. And I think there will always be that slight disconnect between the terminology used perhaps in the public sector and what we use in clinically. But I think it's very important that nasal polyposis in its generality gets the attention that it requires.
Yeah, it's so interesting. Thank you very much indeed, Valerie, for those final words. Well, there you have it. Food for thought, I think you will agree. So two terms, CRSwNP for the medical professionals and nasal polyp syndrome for the layperson. Really fascinating, really interesting. And the brilliance of this is that the change has come from the patients themselves, and that is what you call empowerment. And it underlines what EUFOREA can achieve and how important it is in bringing patients and physicians together to change people's lives. Sadly, that is all we have time for. Many thanks to my guests, to Jeff Preyra, to Thijs Theeling, to Professor Valerie Lund, and also Professor Peter Howarth. And finally, thank you to all of you for watching this EUFOREA Innovation Forum debate. I hope you found it useful, informative, but most of all, I hope you can take away the key messages and maybe change your clinical practice. One final word, you can find more information about EUFOREA and also register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive the latest news via email. And don't forget to follow us on all our socials for all the latest news and information. But from all of us here, goodbye.